You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, we take a closer look at the complex and increasingly important topic of consent management. As more health data flows digitally across systems and organizations, ensuring consent is handled in a scalable, interoperable, and patient-centered way has become a major focus for the industry. Host Tony Schueth, CEO of Point of Care Partners, welcomes two guests from the FHIR at Scale Taskforce, or FAST. Janice Reese, a POCP senior consultant and the FAST program manager, and Mohammad Jafari, co-lead of the FAST consent work. They explore how consent is managed today, what a better future could look like, and how FAST is helping pave the way. We hope the discussion sparks new ideas and perspectives. Have suggestions for future episodes? Drop us a line at podcast@pocp.com or visit the podcast page at pocp.com under the Insights section to share your thoughts via submitting a form.
Hey, welcome to The Dish on Health IT. I'm Tony Schueth, CEO of Point of Care Partners and your host for today's episode. If you're new here, we're the podcast that brings together some of Health IT's brightest minds to dive deep into the most pressing issues and maybe stir the pot a little bit along the way. Today, we're talking about consent management. Yes, that deceptively simple question of who can access what data and when. Sounds straightforward, right? It's anything but. To help us explore the work underway to make consent management more scalable and patient-friendly, we've invited two leaders from the FHIR at Scale Taskforce, or FAST. We have POCP's Janice Reese, who serves as the program manager of FAST, and Mohammad Jafari, who is one of the technical co-leads of the FAST consent work. Welcome to the show. Before we jump in, I'd love to have both of you introduce yourselves. Tell us how you ended up in Health IT and what your role is within FAST. Janice, since you're the program manager, let's start with you.
Yeah, thank you so much, Tony. I appreciate the opportunity to be here today. My initial career started in technology, and I had the fortune and the opportunity to be on the cutting edge of desktop publishing, working with Adobe around the standardization of Acrobat and PDF. And as someone curious about business and curious about how the world works and interacts, especially in the exchange of data and information, I led business development for Adobe and got involved as a global standards advocate, working with the International Cooperation for the Integration of Processes in Pre-Press, Press, and Post-Press for automating things from web to print. You can think about the early days of desktop publishing and some of the capabilities. And at that time, the acronym was JDF, the job definition format. So I help business leaders kind of align those operational processes with emerging automation standards. And we created the Dick and Jane version of, basically the JDF guide for managers, what it means and why it matters, and the impact that it was bringing to the printing industry at that point in time. But it was designed as an educational opportunity for the CEOs and the C-suite that needed to invest in that technology. And by doing that and working with industry standards, it got me involved in healthcare because PDF became PDFH for healthcare. And I got really intrigued, and I happened to be headquartered in Nashville, which is considered the Silicon Valley of healthcare. I got really intrigued with the data process and the document process in healthcare. And that kind of stayed with me. I actually wrote a white paper for Adobe right around 1999, 2000 about how Adobe and Microsoft could be doing more together because of the interaction between Microsoft and Adobe and PDF. And from that, in my career, I also got more involved in cybersecurity around 2015. And that whole process kind of brought me to the opportunity of industry standards, standardization, technology, automation, but how do you actually communicate that in business? And so my whole career, I've done a lot in the multi-stakeholder arena of bringing different people together. In the case of SIP4, it was very technical individuals that didn't really understand that their audience was in kindergarten and everybody else was in college that was working on the standard. And so very excited to have that opportunity to now bring that knowledge to work with FAST because it incorporates many of the things that were part of the problem over the years, which is identity and consent and security and directory. And the idea of having all this data out there that has to be re-entered and reused, and poorly scanned PDFs that people can't get structured data out of because they weren't created effectively. And so all those things drove me to the opportunity of doing something meaningful in healthcare. And I'm excited to have the opportunity to lead FAST and to be involved with Point of Care Partners as a part of it.
You're doing a great job, and we're delighted to have you in this role. Mohammad, it's your turn. I'd love to learn more about you and how you got into health IT and what your role is within FAST.
Thanks for having me on this podcast. It's great to be here. Mohammad Jafari. I worked in privacy policies in grad school and in my PhD work. And so I did quite a bit of academic work on that for a few years. And I was lucky enough to quite serendipitously, meet some people. I want to shout out to Kathleen Connor, who was the first person who came to my talk at the University of Calgary back in the days. And sort of through her, I got connected to the industry. And it was a natural follow-up to the work I was doing at the time. And I considered myself quite lucky to actually be doing something that was very relevant to the research I was doing earlier on in school. And so through that, I got into the privacy policies in healthcare, enjoyed HL7, and following that, I got involved with the consent work from the get-go.
And in talking to Janice and the other members of FAST, your contributions have been substantial. So we want to thank you for that.
I agree. Thank you so much, Mohammad. You're a big part of our efforts at Consent.
I'm excited and happy to be involved. And it's been great working with you, Janice.
And your contributions have been really substantial as well. So we thank you for the work you're doing. But let's talk about the state of play. So consent is the gatekeeper of data access, but today it's often paper-based, fragmented, and painfully redundant. Walk us through how consent is typically managed across the ecosystem. Where are the biggest pain points? Mohammad, let's start with you this time.
So as you said, in a lot of cases, the consent is still paper-based. It's not in a digital form. Then when it's digitized, usually it's not in an interoperable format. So, you can scan it, you can turn it into a PDF, but still, maybe there's some metadata to retrieve it or search for it, but still is not an interoperable format that could actually travel between different systems. And then when it is interoperable, it's often not computable, meaning that you have this digital consent, it is interoperable format, it can be exchanged, but the rules in there are not expressed in a way that would be adjudicated by a machine. So it would need some kind of a manual intervention, or someone needs to read it and enter it into like a database, like a proprietary database. So these are sort of like all burdens to scalability. And I think having a computable and interoperable consent and an API and an ecosystem where it can be exchanged, and also the decisions about consent being communicated is a key element into scalability. And so that's sort of what we are aspiring towards. And then, as you said, there's this, as a result of this, we have these painful friction within the system. On the one hand, it's a burden on the providers and, data brokers because it kind of impedes the sharing of data. It can be an obstacle in providing care in a lot of use cases. It could lead to redundancy because you would have to repeat certain tests, for example, because you can't access it because of consent. But then on the patient side, and this is another aspect of this that's often, not very much highlighted, there is painful redundancy that you have to over and over repeat yourself by filling these forms across wherever you go. And the form is redundant. You already have filled the form that express the same preference, but also you'd have to also repeat the information within the form. Like every time you have to start over, there's nothing pre-populated there, and a lot of these forms are manual. So, it causes a lot of pain and friction across the board for both ends of these systems, basically.
If this were a game show and we were to ask people kind of what's your biggest frustration, that would be one of them. That would be top of the list, which is having to fill out redundant information over and over and over again. So it's exciting that we're making progress here. Janice, is there anything you'd like to add?
Yeah, I think it's also the inadequate integration with identity and security, which are also part of the FAST infrastructure. So consent is often disconnected from a digital identity, which makes it difficult to authenticate individuals and also authorize access accurately. And then I think patients typically can't specify what data is shared with whom and for what purpose, resulting either over or under sharing. And now with the policy variability across states and use cases and some of the challenges about the data associated with that specific to certain states, it becomes much more complex. And many systems can't even set it up today inside of their own network, let alone with an ecosystem, what we're trying to develop as it relates to consent across HIEs and health plans and multiple systems.
Yes, it's exceptionally complicated, isn't it? Let's spell out a vision for modern consent management for our listeners. If FAST is successful and scalable, consent management becomes a reality. How will things look different for organizations who are stewards of this data, the patient, and maybe even for the general practitioner? Mohammad, let's start with you again first this time.
Thanks. I think so there is some vectors of scalability that needs to be addressed in order to have a vibrant ecosystem for consent, where these frictions and the pains that we discussed earlier are kind of ameliorated. And so part of this is the scaling in terms of the number of patients that are involved. So that's one vector of scaling. The other vector is the complexity of the consent itself. So we have increasingly more complex policies that need to be, accommodated. There's rules about minors and, minors who are mature enough to make certain decisions about their health record. There's rules about, certain categories of data, whether or not to share them. So these rules are very complex now. So we need granular and, sophisticated consent rules. And then we also need to be able to accommodate the increasing number of applications. So, it's not just exchange. There is, consent for treatment. There's consent for different forms of exchange with the payers, with pharmacies and so on. So, we have all these like upcoming electronic applications like mobile phones and whatnot. These are healthcare adjacent, but not necessarily within the healthcare realm, but they are working on health data, some of these and then also they generate new data, right? Like some of these mental health apps, they actually are generating health sensitive data that needs to be subject to consent. So we have these, various dimensions of scalability that we need to address. And I think to go back to the point that I made earlier, interoperability is one pillar there, and computability to be able to actually enforce it seamlessly using, machines and electronic systems, as well as the ability to accommodate granularity, to be able to actually have sophisticated rules in a way that would be to the satisfaction of the patient. And then also, as it's reflected in policy, the will and the kind of the collective zeitgeist of what patients want would usually translate to policy and, would come down the stream of the kind of consent that we need to accommodate.
Right. Janice, do you have anything you'd like to add to that?
Yeah, I think the optimal vision for patient consent across the healthcare ecosystem involves three key elements. It's standardized data sharing. So we have a consistent framework for accessing and sharing data. Digital consent, to what Mohammad said, granular electronic capture in a standardized format, which then provides more streamlined workflows, which provides efficient access to and management of the consent. So what consent could be is data sharing with a lower burden, automated processes, and a much better patient experience. So consent management that prioritizes efficiency, privacy, and patient control. And I think that's where, at least from the CMS listening session this week, some of the other aspects, it's definitely coming down to much more patient empowerment as a part of the system. And how do you connect that in a more meaningful way for both sides, everybody, from the standpoint of managing it, as Mohammad was saying, across the internal processes, but also that external process of the actual consumer themselves.
I love that. One of the things that I always remind everybody is that we're patients too, as are our spouses, our siblings, our families, our friends. And so, looking at things from a patient perspective is really important. Now let's dig into the FAST consent work. What's the scope of the project? Who's involved? And why is FHIR the right standard to build around? This time, let's shake it up a little bit. Mohammad, you've been going first. Let's start with Janice.
The Fast Consent Management project is really focused on creating a scalable, interoperable framework for managing patient consent. And so we're working on an implementation guide. We have public calls on the second and fourth Fridays at 1 o'clock Central, 2 o'clock Eastern. And we are getting a wide audience of individuals that are participating in those calls. And we're creating kind of that implementation guide around specific use cases that were identified in all of the work that Mohammad said started around 2023. And then involving the industry players, both members of FAST, obviously members get much more deeper into what we're doing on the use case and participation, as well as the public in kind of understanding what the stakeholder alignment needs to be. What are some of the challenges? We've had recent people attend talking about specific challenges they're facing in reference to what Mohammad talked about earlier on the minors and the process and the different states and the variation of policy. But we're really working with use case-driven workflows, profiles and extensions that will support things like granular data control, digital identity linkage, and policy alignment so that it helps provide that framework for organizations and for companies that are technically developing things to have something as a framework to work from.
Absolutely, absolutely needed. Mohammad, do you have anything that you would add to that?
Yeah, maybe I can instantiate this a little bit more specific to the use cases that are sort of within the scope, because we've had standards before that cover, the content of the consent. There's profiling in if you have a research consent, for example, or if a privacy consent, how do you express that? How do you model that in the form of a FHIR consent? And but the sort of use cases that are around the administration of the consent, these were sort of left to the implementers. And there needs to be some interoperability in order to be able to use and reuse consent and also exchange consent as it's being filed within the system. So that is the kind of the angle that we identified as a gap as we were doing that sort of earlier preliminary study on what can be done here and what's sort of missing from the existing specification. So things are like how to request the consent from a patient, or how to allow a patient to self-initiate, filing a consent. How to collect that, how to record that in a FHIR server, that original raw answer, how to turn that into a computable consent. How to allow the patient to view, their consents or revoke them if they need to, and how to disseminate the event of revocation across the ecosystem so that anybody who's been, acting based upon that consent can actually follow suit and follow the revocation directive that's coming from the patient. So these are some of the use cases that were within the scope. Including the delegation also, like to how to, record the delegation, like an appointment of a substitute decision maker in the system. So I actually encourage everyone who was interested in this to take a look at the list of use cases that we have identified there, sort of like how we kind of delineated the boundaries of the scope in order to kind of stay away from like general authorization, general authentication, access control, and also without really getting into the details of use case specific consent profiles that basically tackle the content of the consent. We're sort of operating based on like an agnostic view of what the consent is, and try to just formalize the processes around the administration of the consent.
And I think it's really around aligning consent, capture, representation, and enforcement with FHIR APIs toward a future where data follows the patient securely and in accordance with their preferences. And I think that, as Mohammad said, is kind of our initial focus and goal specifically. That's
really helpful and encouraging that you're doing that. Janice, you mentioned before that you've had calls where you've had guests where they've talked about the things that they're doing. What are some key takeaways so far, some lessons learned? Are there any surprising challenges or aha moments that have emerged from working with these stakeholders?
I think there is a lot of need for education, to Mohammed's point on where enforcement comes into play and where it doesn't, where FAST is focused specifically on some of the use cases, referencing the process as opposed to specific categories like research or other areas. and helping people understand some of the nuances they need to think about, which is where I think POCP can come into play in supporting some of that education and maybe some of the guidance in outlining that for organizations that are struggling with, they have a patient API, they have a portal, they have data, they have lots of things they're trying to figure out. Where do they start in setting up consent, and what problem are they trying to solve initially? And I think those are areas that we're picking up from the audience and the attendees when they come with these different use cases. Oh, well, that falls in a couple different buckets, but not all specific to FAST and our efforts, but some around this education of enforcement policy, how they need to think about the ecosystem of setting it up, kind of like a Lego piece. What's that design architecture that they need specific for their organization and their use case, and then how that would interact with other organizations that they need to.
Having been on the other side of this, meaning the side that is, preparing to share data, and understanding sort of how complex it is, having some sort of help with, understanding, prioritizing and understanding how the whole ecosystem works sounds like it'd be really valuable. Mohammad, what are some key takeaways you've, heard so far? Are there any aha moments that have emerged for you?
Definitely. I think every time we hear from someone who's actually in the trenches doing the work on the shop floor, they have clear insights about the nuances of how things play out, right? And I think one of the jobs of us leading that group is to be able to translate those into the abstract use cases that we have, to kind of point out, well, like, okay, this portion of the workflow that you have actually corresponds with this abstract use case that we have. And also be sort of on the look to see, oh, this part is actually new. It doesn't fit with any of abstract use cases. We need to actually accommodate a new abstract use case. So, this sort of like bi-directional back and forth, abstraction and instantiation, and then sort of hashing out the details. And I think there will be, some work left later down the road for people who are trying to adopt the standard to say, okay, this is the abstract use case, and this is how we're going to instantiate it. There's going to be details that in that instantiation that still need to be hashed out. And some of those might, in the future bubble up to go into the main specification. It could be a local thing. But I think that, trying to gauge that and dial that, back and forth to sort of like identify what exactly is worth, covering at a high level and would be applicable to many use cases, in different organizations, in different jurisdictions. I think that's been sort of one of the, in at least in my understanding, one of the most interesting part of this work.
I also think stakeholders, from what we've heard, are ready to invest in purpose-aware and policy tag consent frameworks. So especially for behavioral health, public health, and sensitive services, because it's so important to start to manage that information specifically to the policies in the states and the other areas that we're thinking about. And so they don't want it to be all or nothing. They want it to be able to control who gets access to what data for what purpose, and specifically the purpose and for how long, which are definitely some of the conversations we've had, both in the development of the IG, how we would look at testing, and then to Mohammad's point, where does that fit in the rest of the infrastructure, where FAST and the framework are, and where the rest of the organization is and needs to kind of align, especially when you look at digital identity and security as a component of that, as a part of that ecosystem in establishing a consent framework.
And boy, those are two really important things, as you've suggested, digital identity and security. We've had some breaches over the last couple of years that have been really high profile. So a lot of attention has been focused on that. Let's shift a little bit to the collaborative landscape. So FAST is not the only organization attempting to tackle challenges with consent management. How does FAST's approach complement or build on what others are doing? Where can things align? Janice, maybe you could take the first shot at that.
Yeah, we are working really closely with the Sequoia Project. The Sequoia Project has published a really good white paper on consent. We've shared that within our public calls. We are reflecting on our priorities and how we are thinking about structured computable consent, but The Sequoia project has data usability work groups, and they're also obviously involved with TUFCA. So they bring a different aspect of what they've been looking at from the consent landscape. And we're aligning very closely with, organizations like Sequoia specifically, because there's a lot we can do together around what I said earlier, education. Where do things start and finish, and how does it play into the ecosystem? And especially as the administration begins to open up what they want to do and where they want to go. Again, we heard this week that identity is going to be a big focus from the CMS listening sessions, but identity then will lead into that topic of consent, because if they want to go after identity specifically, I think for Medicare as their first target as an initiative, then it becomes, well, what do I want to, or individuals want to be able to allow relative to consent into that what purpose, what aspect. We're also working closely with, care quality, direct trust, other initiatives that have ecosystems and networks to figure out how do we play, tying in closely with the Kantara initiative and some of the work they're doing. So they're also involved. So we want FAST to be kind of that collaborative infrastructure, but understand where each of these organizations are involved, and then how do we come together to specifically drive more education around where it is, what matters, and then how we are working together so people don't think that we're competitive, but we're all aligned in kind of getting to the same end goal. It's just a matter of what each group is focused on.
Absolutely. Mohammad, do you have anything to add to that?
There's two aspects to this. One aspect is like organizations and groups that are actually consumers of consent. People who are involved with running the national networks, and also at the state level. I want to add that there are use cases at the state level for state level jurisdictions, and there's organizations involved with that. So that's one aspect, to collaborate with them in order to make sure that the use cases are covered within the scope of what we're doing. And then the other aspect is also collaborative organizations that are actually working on doing technical work or business analysis work in this space. So when we did that initial sort of landscape analysis, we sort of identified a number of different groups that are doing this work at various levels. Some groups are working on like a use case business level. Some people are developing technical architectures, but at a very high level. It could be technical architecture at a very specific, implementation guide level, and then all the way to, proof of concept and reference implementation. So, there's other also adjacent HL7 and FAST work, like Janice mentioned. The identity work within FAST is quite adjacent and interconnected with consent, as well as I want to actually mention the IHEPCF privacy consent on FHIR, which is a specification that covers the content of privacy consent and also some of the lower level transactions. So we're in touch, we're aligned, and we're making sure that we are also not overlapping and sort of deferring to existing standards where it's appropriate.
And also working with like Gravity, another accelerator where consent was a topic that came up earlier this year in some conversations, because there needs to be consent in reference to obviously data that needs to be shared as a part of their process. So we do cross work across other accelerators as well within HL7, Public Health, Helios, as well as Gravity, and doing quite a bit of work with Da Vinci as well.
Obviously, we're familiar with all of those, especially Gravity and Da Vinci. Let's pivot to taming the policy beast. One of the biggest barriers to scalable consent is policy fragmentation. That is, different rules in different states, sometimes even across departments in the same organization. How is FAST tackling that tension between policy variation and technical scalability? Janice, could you take the first shot at that?
Yeah, I would say that we're standardizing the structure, not the policy. But we're standardizing the structure, as Mohammad said, in a way that we're getting feedback, because there's a much bigger interest for states right now, because the federal government is moving more information and requirements down to the state. So we are looking at how we can help standardize that consent framework, but not the consent laws or policies themselves, because they're going to vary and differ, and they could change quite frequently. We have to have a system that would allow that to kind of be aligned. So we're aligning with NIST, we're aligning with OAuth and UDAP and OpenID and other industry standards that help kind of bridge human policy and automation. So we can have the automation and the capabilities that Mohammad's discussing, but we allow organizations to set their framework, their policies, and how they manage that as a part of what we're doing. And that's what I mentioned earlier, that there needs to be more education around the capabilities of what that means, because you've got a lot of states that are adjacent to each other that have different privacy laws, that have different rules on certain aspects of delivery of certain services. Those are all things that are important, but we have to be able to help let people know we're not trying to get into the policy discussion, helping them arrive at the right framework.
You know, that's something that we are very attuned to, which is different states having different rules, laws, regulations, et cetera. Can you give us an example of a couple of states that maybe have a variation in laws, rules, or regulations?
For myself, I can say that the state I am in, Tennessee, has certain laws around delivery of certain services, specifically in women's health, that are different from other states that are right next to us. We have obviously California, which has a much higher level of privacy and requirements for their constituents in the state of California than any other state across the U.S. and the process of where they are. And so not only do you have to think about what the policy laws are across the states, but you have to think about the deeper aspects of certain services, specifically in women's health right now, that could be challenging based on what state does what. And based on different aspects of what Mohammed said earlier, if you have a minor that gets, maybe has parents that live in two different states and is of a higher certain age as a minor, but has a service in one state that the other state doesn't allow. So those are some of the complexities and the conversations we've had within our consent efforts to try to identify the different things that might come up relative to both the use cases, but also the complexity of scenarios with, divorced parents and certain services and certain individuals and what that would look like and how to manage that and what's breaking the glass, what might need to have much more kind of analysis on these specific, very detailed types of use cases that get a little more complex.
Mohammed, do you have anything that you'd add to that about, different states having different rules, et cetera?
Yeah. So, I mean, one thing I want to say is that, that is sort of part of it is maybe not desired. We can, aspire to have better harmonization across the board, but part of it is also natural because different jurisdictions have different drivers of policy, different customs, different, expectations and general expectations from the patient. So that's sort of driving the fragmented policy in a way that, it is actually natural. And what we need to do is to actually be resilient to accommodate those. And the key to that is interoperability. To be able to have, computable, flexible rule implementation rather than, hard coding for one state and then, having to redo the software engineering for another state, having able to dynamically accommodate rules as they change also in individual jurisdictions. That is something that is part of the key to the technological piece. So that's one aspect. And I think the other aspect of this is that some of the disparities also sometimes a result of the regulator being hesitant to require something. Like there was this general spirit that, for example, you need to have consent for sharing sensitive information. But if you don't have the specification, they wouldn't go as far as to require how. And then that would leave a lot of wiggle room that would lead to disparity and, local policies and then local, organizations, lawyer, trying to, cover for something. And then, so having the exact kind of specification that we're working on and the sort of the, showing the feasibility through technological means also gives the regulator the confidence to go further and say, here is, the interoperability standard you need to follow to, for example, for consent administration. And that would help across the board to sort of reduce some of these tensions and have a more unified, ecosystem and infrastructure.
And I think that's why we have security labels and obligations. There's, block sharing unless the purpose is treatment associated with. That's why purpose and treatment is so important as a part of the process and the scope. and allow sharing only if the user is in network or authenticated at a level 2 assurance from an identity perspective. So, all of those layers of what we talked about with identity security, as well as managing the actual data inside the computable consent itself as a part of that process, as Mohammad said, is fluid as we support open standards and where NIST is with their efforts with identity and other aspects and other organizations that we are working with. But giving the flexibility so an organization can still have automation without being concerned with their legal and other individuals are going to come in and say, wait, what are you guys doing now?
Right. I've never had legal and do anything like that. Ask me, what are you guys doing now? All right, let's we're kind of to the final word. Before we sign off, are there any final messages or calls to action to our listeners? This can be broader shifts in perspective that you'd like to see and how you'd like to see them approach consent, or other related areas differently within their organization, or anything you want them to know. Mohammad, let's start with you.
I would start by just saying that, we are at a very interesting juncture now. We've had the technology piece, both at the standards level and also like at the vendor level, implementation, reference implementation pilots. This has been in the works for over a decade now. And so the technology has matured to the state that, we have the confidence that the technology is there, the specifications are there. And there's also, on the other hand, from the consumer side, there's the expectation of privacy. There's a lot more awareness about consent. And the regulator also has the appetite to accommodate that. So we have in this interesting juncture where all these three forces are sort of at a confluence. And I think it's a great time to actually, take the next step and go to the pragmatic levels of implementing things and getting it done. I know, in the prior years, there was always sort of this skepticism in various actors, on the regulator side, because these are also very much interconnected, and people sort of are in this situation where they have to kind of make sure they're all kind of stepping at the same pace. Otherwise, one force can get ahead of the others. So I think we're at a good time now where everything is right and all the forces are aligned. And it's a great time to be investing into the next step of consent administration and enforcement across the board.
I would agree that the stars are aligning. How about you, Janice? Do you have any final messages or calls to action for our listeners?
I think with the CMS listening session that took place yesterday and the impact of what they're wanting to accomplish is a significant foundation for the work that all of the accelerators have been working on in HL7 in context, but in effort fast, because we're the plumbing, we're the infrastructure. Mm-hmm. And the opportunity to get engaged with FAST now, especially around the focus on identity and how identity then flows into consent. Our FAST security implementation guide is going to be required in January of 2026 for FHIR over TEFCA and some of the initiatives that are growing to bring a more trusted, secure foundation. And so organizations need to think about automating consent as a part of that. And so the time is now to get involved. We have public calls. We have a lot of interaction with the industry on educational webinars and ways that we're outreaching. And we want to hear more about use cases as we continue to prepare for launching our consent implementation guide and for testing it later this year in September. We've already got 2 technology companies that will be testing with us, committed, and we're looking for more use cases and opportunities and interest from the industry.
So there are public forums that people can listen, anybody can listen in on. And then there's also, they could become a member of FAST, they could become more active. How would they go about doing that? Either of those?
They can email us at fast@hl7.org or reach out to myself individually on LinkedIn or email myself. But we have had several new members this year join FAST and get more involved, specifically in consent and identity because of some of the things that we've mentioned. And we welcome anybody to come to the public calls. As I said, consent is on the 2nd and 4th Fridays at 1 Central, 2 Eastern. All of our rest of our calls are set on the HL7 public calendar to be able to join. But I think given the momentum with the administration, given the move from the administration to work closer and have the states do more work, we're finding that there's definitely more interest with state CIOs and state public health departments. So we want to get those individuals and those companies involved in whatever way possible. So happy to have them. And we have a LinkedIn page as well that they can follow.
And it's janice.reese@pocp.com, correct?
That's correct.
Okay. Well, listen, I think we're to the point where we're going to sort of wrap up. And so I want to thank both of you for joining us and the critical work that you're doing right now. To our listeners, if you found this conversation helpful, tell a colleague, share the episode, or subscribe to the Dish on Health IT on your favorite podcast platform, and leave us a positive review, please. And remember, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interoperoutlook@pocp.com to learn more about our Interoperability Outlook subscription monitoring service.